Hi, welcome to IANS Health Talk with Dr. Akram. I am Akram. In this program, we'll be talking about all different health issues with different experts in the field. Today, we'll be talking about respiratory failure. So sit back, relax, and enjoy your time with us. We all know about heart failure, liver failure, kidney failure, but we rarely give attention to respiratory failure, a condition which can be prevented and treated if we tackle it early in its stage. What is respiratory failure? When the lungs fail to oxygenate the blood or fail to wash out the carbon dioxide, or both in some cases, is called respiratory failure. Certain conditions such as asthma, chronic lung disease, or certain lung infections can lead to respiratory failure. The major function of the lung is gas exchange. The inhaled oxygen passes through the airways such as the nose, larynx, pharynx, bronchus, and to the lungs. There are two parts to the lungs, the left and the right. They divide into multiple lobes and lobules into alveoli. Alveoli are millions of small air sacs. Their total surface area is as big as a football field. The alveoli are enveloped by millions of tiny blood vessels. Gas exchange happens here in this interface. Oxygen dissolves into the bloodstream while the carbon dioxide dissolves back into the alveoli due to concentration gradient. When this interface becomes diseased, thickened, or blood supply gets interrupted due to certain conditions, lungs fail to do its job, the gas exchange, and we call it respiratory failure. Today, our aim is to understand this condition in detail, such as its pathology, contributing factors, and much more. So, let's welcome our special guest, Dr. Mohammed Ramali. He's a consultant anesthetist in Essex with special interest in intensive care medicine. He teaches medical students and postgraduate students. And he's a research lead of the hospital. He was looking after numerous COVID patients with respiratory failure. And also, let's welcome Mr. Albert Banho, who had first-hand experience with respiratory failure during this pandemic. Mr. Albert Banho works in Essex as an ODP and as a theatre nurse. He was working hard treating COVID patients when he contracted COVID himself. We are going to learn from his first-hand experience in tackling respiratory failure himself. And also later in the show, we'll be joined with Mr. James Clarin, who was suffering with respiratory failure due to COVID. He was cared and treated by Dr. Ramali and his team. He was on ventilator and survived his COVID attack. He will be joining via Skype as he is not yet fit to travel to our studio. So please sit back and spend your next precious hour with us. Welcome on our show, Ramali, and welcome, Albert.
Thank you. Welcome. Thank you.
How are you feeling today?
Relaxed. Happy to be here. Thank you again for inviting.
It's a great topic we're going to talk, isn't it? Respiratory failure. Not many people know about it. But before going to the subject, let's talk about you guys. Ramali, what are you? What do you do generally?
Well, Akram, I'm a consultant anesthetist with special interest in intensive care medicine. So I've been now doing it for nearly 27 years, so loving my job. And even better, you don't see many anesthetists coming out and talking to public. We work behind the show, behind the mask. So thank you for inviting me to talk about this very important topic. And you got the timing right as well. We got a nice lull after our first epidemic. So we can think about what we've done in the past and how we could do it better. And nothing like educating the public on a topic which is not very talked about. Because if you involve the public in management, the management is better. Thank you again. And can I also commend you for choosing these topics and doing a great job, because all the topics I've been following your program and nicely chosen topics, and public need to be known about these things. You know all the misinformation before the COVID, That's because of ignorance.
Ignorance, true.
Thank you very much again.
That's our main aim anyway. We are trying to bring the best for the public from Iron Studio and our team who are working really hard behind. And Albert, you come
Hi.
from Philippines, and what do you do here in UK?
I came in initially I work as a nurse in a nursing home. Then my training back home is theatre, so I said it's better off with me to go back to theatres, and I've been working in theatres for quite some time now. And part of an extension of my responsibility is as well is I was trained as an ODP, so I work
As
both-
operating department practitioner.
Yes,
Is that
and as a nurse at the same time. Yeah,
right? Same time.
yeah.
And you are assisting lots of big operations, you know, all the surgeons and all these guys doing there.
Yes, mostly, but I looked after most on spine and orthopedics. But since I started working with the anesthetist, I learned to appreciate more the anesthetic side of it, and I love working with them as well.
Excellent. And Albert, you are here because during the COVID, Albert was working and treating the patients with COVID, and you were carrying patients who were on ventilator. And
Yes.
you had an experience with them, isn't it?
I have.
We will talk about it a bit later.
Yeah, thank you. Yeah.
And you suffered with COVID as well, is that right?
Yes.
Okay.
Yeah. Thank you.
Great. Okay, great. So what we do, let's talk. What is this respiratory failure about?
Right. So Akram, you mentioned in your introduction what does the lung do. So they take in oxygen and put out carbon dioxide. So you are looking at two functions here, because which both are essential. So either of them or both could fail. So taking in oxygen, if it fails, you can call it a type 1 respiratory failure or hypoxemic failure. So equally important, the second function of the lung is putting that carbon dioxide out. So if that fails, that is also a type of failure. So we call it a type 2 respiratory failure, which is hypercapnic respiratory failure.
Right. So first you said is the lung cannot oxygenate the blood. The second one is the lung cannot wash out the carbon dioxide.
Yeah. So I just lung is only a part. You know, the lungs and the heart couldn't work independently. So no point getting those oxygen into those small sacs, alveoli you mentioned, if that cannot be transported into the cells.
Exactly.
So because oxygen is vital to all the organs.
All the organs.
Kidney, brain, heart. So if the circulatory system or the heart doesn't work well, no point having the oxygen in the lung. Same way, the carbon dioxide is actually produced in the cells. It needs to be transported all the way to the lungs to be excreted. So if the circulatory system is not working well, again, it can lead to failure. So
this oxygen is provided by the lungs, and then we have a pump, which is the heart, and the blood circulation, which carries this stuff and taking into distant part of the body.
Yes.
And our brain tissues,
exactly,
etc. How common and how common is it, and who gets this kind of respiratory failure in general?
Yeah. So both are common. So there are either you can divide it the way I said, classified, or you can classify into the timing of the failure. So like we saw during the COVID pandemic, lots of patients were coming to A&E, and there were big talk about ventilators, we had to build capacity. That's an acute respiratory failure. So you don't have much time, you have to act quickly. Because any system to fail.
That happens in the tropics as well with respiratory infections, isn't it? Lung infections.
Exactly. So that's what I just want to talk about, the type 1 acute respiratory failure, because lack of oxygen is going to be a disaster, and you lose consciousness, your other organs going to get affected. So common reasons are infections. So you've seen the COVID, which is viral. Equally, there's another population who suffers from non-COVID viral infection, and also acute bacterial pneumonia. So pneumonia commonly known to
That
the
must
public.
be quite common in Philippines as well, isn't it? You must be working there.
Yes, pneumonia is common. I don't know if I consider tuberculosis as well.
Tuberculosis.
Yeah, so tuberculosis is a chronic condition.
Chronic condition.
Right? So that there are other conditions which causes chronic respiratory failure as well. So you will see sometimes patients moving around with oxygen. So it's rather than the quality of life. Then, so that group, the chronic respiratory failure, they get used to their capacity, because I just wanted to go a bit deeper into respiratory failure. Any system to work, there's a capacity and there's a demand. So now I'm talking, I've got enough reserves, I got a good capacity. If we run, we do exercise, we use those capacity. Some patients are prone to get these illnesses, and they are already, like patients like COPD, brittle asthma, patients who are immunocompromised, their reserves can go down very quickly. And when the demand goes up, like an infection, viral infection, they struggle for oxygen. So this is why I said it's very important for the public to know when to get help and get to know more about the disease, and to come to hospital when it's needed, because there was a lot of fear during the COVID pandemic, whether we should go to hospital or stay a bit more at home, and all this advice, because going to hospital itself, people were worried. Could be risky, you might get infected. I'm sure the pulse oximeter, we wanted to buy one for our household, couldn't get one. Everybody had bought one, and they were monitoring the oxygen saturation at home.
Can you explain a bit about this pulse oximeter? What does it do at home, and how does it work in home?
Yeah, I mean, it's
it's a small machine.
Yeah, we use it in theatre or in ICU to monitor a patient's oxygen level. So usually on room air, when I'm breathing like anything above 96% is acceptable. It's good. So at home, the issue was during COVID, the advice was, if you find it difficult to breathe, come to hospital. But patients want to find out what their oxygen levels are.
True.
So it's a small device where you put it into one of the fingers, usually index finger, and it's called plethysmography. It's a bit, I don't want to dwell into that. So it picks up your pulse, peripheral pulse, and does a bit of calculation and give us a reading. So at home, if you are having respiratory difficulty, if you put the pulse oximeter on, if it's below 94%, you should go to hospital.
So the pulse oximeter is a small gadget.
Yes.
You keep it there, and there is a wire, and you hook into one of your thumb or something.
Yeah.
Then it gives a number, isn't it?
Yes. Yeah, it gives two
maximum number
numbers.
is 100.
100. Yeah, it gives two numbers. The percentage is your oxygen level.
Yeah.
There's another number given which is a pulse rate. So it will tell you, it's important to know, if it's going at 120, 140, your heart's not working well either.
Yeah.
So you can make use of it, and it doesn't need to be connected to via Akram, the portable one. Very useful. Battery, and you just put it on and it gives a reading.
It gives a reading. Okay. This is a live program, so call us on 0203 515 5788 if you have any questions or suggestions, or write to us healthtalk@intv.co.uk, and you can also follow us on Twitter and Facebook, Iron Health Talk with Dr. Akram, and our dedicated YouTube channel, Health Talk with Dr. Akram. And of course, you can watch us on Facebook Live, intv.co.uk. Okay, we will show this in visual. I think we need a bit more interaction. Let's play a video. This video is all about how the oxygen is transported to the lung, and how it's been moved to certain part, and how it's been grabbed by hemoglobins and transported.
The respiratory system moves air through the nose, pharynx, larynx, trachea, and bronchus to to the alveoli where the gas exchange between oxygen and carbon dioxide occurs. Nares are the openings to the nose. The nasal cavity is lined with cilia, mucous membranes, and blood capillaries. The air is filtered by cilia, moistened by mucous membranes, and warmed by the blood. Air moves into the pharynx or throat, the common passageway for food and air. Air continues on to the larynx. The epiglottis, a flap of tissue in front of the larynx, closes off the larynx when swallowing to prevent food from entering. The larynx or voice box contains the vocal folds. The trachea or windpipe connects the larynx to the bronchial tree. The cartilage rings of the trachea prevent the trachea from collapsing. Lungs are spongy tissue with alveoli and blood capillaries. Breathing occurs because of the expansion and contraction of the lungs. The bronchi carrying the air subdivide into smaller branches called bronchioles. At the end of each bronchiole are the alveolar sacs. The alveolar sacs are surrounded by blood capillaries and contain millions of single-layer alveoli cells where the gas exchange takes place. Oxygenated air goes from the nose to the pharynx, larynx, trachea, bronchus, and alveoli. By the process of diffusion, oxygen in the air moves from the alveoli to the capillaries. Carbon dioxide moves from the capillaries to the alveoli and is exhaled. This process is called respiration.
All cells need oxygen. It is the essential fuel which is necessary to enable cells to stay alive and to carry out their various activities. Bringing oxygen to the cells requires the uptake of oxygen from the air in the lungs, its transportation in the blood, and its delivery to cells all over the body. The first step is the taking up of oxygen by blood flowing through fine capillaries in the walls of the lungs' air sacs, or alveoli. The oxygen molecules change from their state as a gas freely circulating in the air, dissolving into a solution in the plasma within the capillaries of the alveoli. Once in the solution of the blood, 98% of this dissolved oxygen is taken up by passing red cells, leaving just 2% remaining in the physical solution unattached. Red cells are particularly well suited to transporting oxygen because they contain a special oxygen-binding protein known as hemoglobin. Each molecule of hemoglobin itself contains 4 molecules of heme, an iron-containing pigment, which binds oxygen loosely and reversibly. Hemoglobin that is fully saturated with oxygen is bright red and is called oxyhemoglobin. On the other hand, hemoglobin that is not saturated with oxygen is purplish blue in color and is called deoxyhemoglobin. It is heme which makes it possible for the red cells to pick up oxygen dissolved in the blood, transport it combined with hemoglobin, and release it back into the blood as oxygen in solution, ready for delivery to the various cells of the body.
So, Romilly, let's say about types of respiratory failure. What kind of respiratory failure are there?
Yeah, so as I said, it's classified as type 1 and type 2. Type 1 is lack of oxygen. Type 2 is excess carbon dioxide. So those are the two main functions.
Two main functions.
So although I hope we can differentiate. So we talked about lungs, but we are talking about respiratory failure, not lung failure.
Lung failure.
So the differentiation is very important because for the lungs to work, there's a whole sort of chains. So starting from your brain and your nerves and your muscles. So brain needs to give a signal, start breathing. So problem at any of those links can cause respiratory failure, especially type 2. We see patients come with overdose. So that suppresses your brain. So then breathing becomes less.
That's true.
And they get hypoxia. Patients having a road traffic accident can have C-spine injuries, and the muscles don't work because the nerves need to tell the muscles to work. That's another type of respiratory failure. Coming down, working around the ribs and muscles. So Guillain-Barré syndrome, you would have heard some condition.
That's an infection, isn't it?
Yeah, virus, but precipitated by virus, it's a nerve. infection. And so it depends on where in the link the problem is. So that causes more of a chronic respiratory failure, which is type 2. But mind you, these are mixed. So say a patient's got type 2 respiratory failure, COPD can have hypoxia as well. So you see either different, categorized into 1 and 2, but could be mixed as well.
Okay, Albert.
Yes.
Let's talk about you. What happened to you?
Because when the COVID starts, we all before it started already, we were told that of the conversion of the whole theater area to be converted into an intensive care unit.
So you're looking after patients in theaters, isn't it? There were lots of patients there.
Yes, and one of those times that I was on, we have a patient that is very anxious, and in the end started on to being put into a CPAP. And because of his anxiety, he doesn't, I think, he find it really difficult with the CPAP, and he keeps on taking it off.
That's the mask you put on the face and you ventilate
which
the patient.
it gives in positive air pressure onto the patient to help blow up the lungs to give us some more oxygen. But because of that, I think even though with all the PPEs that we got, you still get exposed to that patient, and I think that's,
so you got exposed to that patient who had COVID.
And I think that's how I get it.
And how did you feel that you were ill?
It started off having a low-grade fever.
Low-grade fever.
Yeah, and then after that I started having diarrhea, and initially I thought this is nothing to do with anything of respiratory. And then only to realize that when you looked at on the Wuhan side, that they said part of it is diarrhea. But then after that, that's when you start, because I'm asthmatic at the same time.
So you're asthmatic, so you have one.
So luckily enough, I got myself sorted out with the asthma inhalation. Inhalers that I have. I got that sorted out. So thinking that you're going into COVID area, which is respiratory, plus it doesn't help with me being asthmatic. That's when luckily enough it helps me. And when we were told also that patients will be prone, which helps the patient in a way.
Face down,
which helps the patient at the same time the lungs to be able to inflate more.
That's quite interesting, isn't it? It's like in tradition, parents tell children not to sleep face down, isn't it? But it helps breathing anyway, so that's a good point.
I only realized that yes, it helps him a lot, because normally with asthmatic, most of the time you sit up just to make yourself comfortable, and then you can breathe.
Expand your lungs,
But this time I said, if it helps being prone, that's when I realized, yes, I'm more comfortable being on prone and able to.
So you had the respiratory failure, did you?
I would say it's not that as bad as looking at my patients in ITU. It's not as bad as that.
So to diagnose respiratory failure, clinical diagnosis you can suspect, but they need to come to hospital. You have to do a test, which is called arterial blood gas. So if you do that test, if your oxygen level, so just for simplicity's sake, I'll say level, so PaO2 we call it, arterial oxygen.
Partial pressure of the oxygen in the blood.
Has to be at least 60 millimeter of mercury. If it's below, then that's a definition. And same for type 2 failure, you measure the carbon dioxide.
Ramali, we're going to talk more about this after the break. So in our show, we have our special guests, Dr. Ramali and Albert, who had first-hand experience, and we're going to get joined with James Clarin. James Clarin had contracted COVID, and then he was treated in one of the hospitals in NHS by Dr. Ramali and his team, and he was on ventilator, isn't it? Then he survived it. So James, sorry, unfortunately you couldn't come to the studio. I heard that you're not still fit. Anyway, welcome to the show, James, through Skype.
Good evening.
James, how are you doing today? How are you feeling?
I'm feeling good today. I still have the problem with my shoulder. That's what I'm really
Oh,
suffering after the COVID.
after the COVID. Okay, James, tell about sir, what do you do generally? What kind of work you do? You have
I'm a
family
support
here?
worker,
Are you a support worker? So you looking after people?
learning disability
Okay.
client, adult clients. Yeah.
Okay. So where did you contracted this COVID? Do you know where it is? Is it from your work or is it from the street?
I think it was on my ward.
Uh-huh.
One of my patients have died from COVID pneumonia, so I
Okay.
think actually
James,
it was
tell us what happened in the hospital. When did you feel that you could not breathe and you wanted to go in the machine, the ventilator?
It was on the 7th of April that I was feeling body ache, headache. I presume that at that time I was just presumed that it was just not feeling well. But on the 10th I was coughing. Then on the 13th of April I was really coughing a lot. I cannot breathe. So I called up the ambulance.
So
On
you
the
called an
morning,
ambulance,
the
yes.
ambulance brought me to the hospital. And the evening I was intubated by the team of the doctor, headed by Dr. Ramali.
Do you know how many days were you on the ventilator for?
I think it was 38 days I was intubated. 38 days.
38 days. It's not 8 days. I thought it was 8 days, but it was 38 days, more than a month.
More than a month, yeah. Yeah, it's really difficult. During those times, I cannot, only I can remember is somebody will hold my hand and will talk, then will say, grip my hand, if you can feel me, you can hear me, just grip my hand. So I just try to grip it. And then I have lots of hallucinations.
Okay.
Like I was underwater all the time. I was underwater every time. I can feel that.
So James,
there's a guy.
James, first of all, you are a good fighter. Man, you came out of this ventilator after 38 days, and now you are explaining about how you felt when you were under ventilator. That's you explaining, isn't it? So you were hallucinating, you were feeling as you were underwater all the time. Were you hearing people talking around you?
I think it was on a week before my birthday that I can hear them very well, because one of the nurses that look after me told me that be strong because next week is your birthday. So my birthday is on May 11th, so I'm already almost a month here, but there's some time that I can hear and can feel, but my eyes is just closed and I cannot talk because of my tracheostomy. I cannot talk
So you had a
really,
tracheostomy as well. Okay, James, let me ask Ramali, who looks after you. Ramali, can you explain how it happened with James?
Yeah, so as James correctly said, he had type 1 respiratory failure. So quite rightly, he got an ambulance, came to hospital, and he soon realized that he needed to be supported. So I tried CPAP, I don't think it worked.
CPAP is the mask you
Yes.
put on the face and try to ventilate from outside without getting a tube into the throat, yeah?
So we had to pass an endotracheal tube into his lungs or trachea to look after his breathing. So what happens usually, so by that time James went to sleep, so fully anesthetized, and after about 24 hours, the natural course of this disease, it gets worse.
Worse.
So the oxygen levels drop drastically. So you will have to, like Albert mentioned, we had to prone them. So that actually helps oxygenate the lungs which are not
So
dependent.
explain, proning means you put the patient face down and they sleep.
That's correct,
like that,
yeah.
yeah.
So I don't know whether you remember James was talking about shoulder pain.
Shoulder pain.
So he was prone for a long time. So you don't keep the patient prone in one go for more than 16 hours. So you put them back onto the back and then give them a rest and then prone them again. This people may not have understood. It's not, when we were working in ICU during pandemic, it's not only playing with ventilators and drugs.
Yeah.
We needed people to do these things. So you need at least 6 people to prone one patient.
Manual
and when you
work,
have about 20, you have timings to do them.
Yeah.
And same the other way as well. So James went through a lot. And he obviously, after that amount of period of ventilation, you just can't take them off the ventilator quickly. So we had to do a tracheostomy. My colleagues did a tracheostomy.
Tracheostomy is you
make a hole
into
the throat, the windpipe, and let them breathe through that. So you have a gradual, we call it weaning, coming off the ventilator. So you can reduce your sedation, you can have access to the trachea directly, you can clear secretions, and it's a gradual thing. Because
so it's basically, if you have a tube through your mouth is more sensitive, isn't
it?
And you can't bring down the sedation and all the drugs.
Exactly.
So that's why we do this.
And it's a big step to take it out. Whereas tracheostomy, you can reduce it, because when a patient is getting better from a ventilator, it's a gradual withdrawal of the support of the ventilator, and you let the patient do a few steps at a time.
I think this is because they are on ventilator for so long and the muscles forgot to work.
Exactly. So this is another thing I was telling. You need not only the lungs, the whole system. From the brain to the lungs to work. So they have very weak muscles. We call it critical illness myopathy. And as I'm very happy to say, James I've already assisted him by looking at talking. He's not in breathless talking to us. So which is a good thing, James. Keep up. He's been very good. He does his own rehab, and he's got a fantastic wife looking after him, and she does with all helping. And I mean, I've seen them going for walks, physios, and he talked about birthday. He's celebrated a birthday yesterday, James. It was his wife's birthday yesterday.
James, was it your birthday yesterday or your wife's birthday yesterday?
Yes, my wife.
Happy.
I was your wife's birthday. Excellent. Okay, please go ahead to explain. Yeah. Okay, James, thank you for joining with us, and it's an amazing to get this first-hand experience from you, especially how you went through it, and it is really valuable for viewers who are anxiously waiting to hear from people like you who had first-hand experience, and that's why Albert is here. He had same experience, and but. Luckily, he didn't have to go that much to the ventilator, but you had problems with breathing, isn't it? Okay, James, be there, and we're going to continue the program. Let's talk a little bit about the respiratory failure prevention, what the exercise and smoking, and what can we do on this aspect.
Very important, Akram. Now, during the COVID pandemic, public realized the importance of being healthy. When it was all over the media saying that if you are healthy, if you are fit, if you've got good lung function, you will get a mild infection. Certain diseases you can't prevent. Somebody is diabetic, asthmatic, on steroids, or kidney disease. But there's another group of patients who can be even healthier, right? Patients who are smoking, not doing much exercise. So it was a good wake-up call for them. And people started talking about immunity as well. So to boost up your immunity, so take vitamins. So lot of things been thrown about, like some medications like hydroxychloroquine. People started taking them. Thank God it was stopped after that, because there were lots of side effects. So it's basically leading a healthy life. So my advice is regular exercise, try and stop smoking, and get your flu jabs.
Normally, there's something like every time I bring a speaker, they always say, stop smoking, stop smoking. I bring a back surgeon, he says, stop smoking. Then I bring a vascular surgeon, he says, stop smoking. Then I brought somebody about diabetic, he says, stop smoking. What is this smoking?
It can affect lots of organs. So it's not only the lungs, heart, you can get heart attack, it's I mean, it causes any other organ dysfunctions leading from. So like for your respiratory system, you were talking about in your video, your cilia functions. So that's all got depressed. And then your clearance of secretions is not good. And it causes persistent tachycardia and affects your heart. So on top of this respiratory failure, you have a heart disease, that's even worse. So if somebody is not thought about it before the cases go high again, it will be a good time to, it's not easy for me to say from here, but there is lots of help given in the community if somebody wants. To be fair, Akram, I've seen now lots of young people talking about more healthier lifestyle.
More healthier lifestyle?
Absolutely. And then I think young people are not smoking as much they used to smoke in the past. That's a general
smoking
feeling.
Is considerably less than before, isn't it?
Yes.
Is it same in your community as well, or do a lot of people smoke in where you come from, or Philippines, or where you work generally?
Initially, for the young ones, it's more on peer pressure, I would say.
Yeah.
Then you start smoking, and then some of us who get hooked on it because of the peer pressure, and then some of us do it as in for socially. But I never get hooked to it, luckily enough for me. Yeah. Plus, it doesn't help with me being asthmatic. Yeah.
So let's talk about how does this respiratory failure present? How can you suspect it?
So, as Albert was mentioning, so one of the initial sign is shortness of breath. So patient will, it's going back to that reserves and your capacity and your demand. So when your lungs, so when you have an infection, say you said the air sacs are full of air and oxygen comes in. So when you have an infection, be either it's a viral or a bacterial, that air sacs are filled with either fluids or they collapse. So then the oxygen can't be transported from your lungs to the blood. So then you start to feel air hunger. So you are short of breath.
Short of breath.
So you have to, we talk about resuscitation. We always say A, B, C, airway, breathing, circulation. So get your oxygen onto the patient, make sure the breathing is fine, and make sure it's transported into the organs. That's vital. So you correct the airway and breathing, and then maintain blood pressure and things like that. So by giving oxygen to the patient, you increase the oxygen. But sometimes it's not enough because your air sacs are either collapsed or there's lots of fluid, the gas exchange is not happening. You might have to give some extra help like the CPAP machine, or which sometimes not enough, you have to put them on a ventilator.
So that's the time you come as a doctor and Albert come
as
to help us. Yeah?
Yeah. Very useful to have. In fact, in our hospital, it's mandatory even in ICU. If you need to put somebody on a ventilator, if you want to pass a tube into the trachea, you have to call an ODP.
Operating department practitioner.
Albert, we can't do it because they are, whenever we are in theatre, they are the people who help us.
They technically know a lot of things, isn't it?
They are very good, and they prepare well, make our lives very easy. And by working with them for such a long time, they basically know what, and they help us do a very safe job.
Yeah. That's true.
Thank you, Albert.
What tests can we do for respiratory failure?
Yeah, again. So, to diagnose respiratory failure, acutely I'm talking about, you have to do the oxygen levels and make sure they are safe. So, make sure they get enough oxygen. Then you have to find the cause, because if you are not treating the cause, it will go on. So, like a bacterial pneumonia, you have to get antibiotics on board. Unfortunately for virus, we didn't have, we just supported the organ. So you have to do a blood count. So we call it white blood cell count, which will tell us whether it's a bacterial one, or you can make some inclination as to which type.
Which type?
Chest X-ray, don't forget. In your video, you showed some chest X-rays.
Chest X-rays, yeah.
That's an essential thing to diagnose chest infection.
That's the first thing. X-ray has been there for a long time in the medical practice.
Yeah, so you can see whether a lobe is affected, or you have this consolidation, you call it, or COVID, it was supposed to be a widespread sort of a change as you feel. It's not confined to one lobe.
One lobe, yeah.
So X-ray was very useful for us during COVID time, because you can't put everyone through a CT scanner, because we were getting so much patients. So we used the X-ray to make this diagnosis. And don't forget, while you do these tests, you have to look after the other organs as well. So your ECG, because sometimes heart problems can present as respiratory failure.
That's a quite important thing,
Yes.
isn't it?
Yes. So a heart attack, a patient going into failure, can present as shortness of breath and low oxygen. So, and
heart failure can fill up the lungs with fluid.
absolutely, we call it pulmonary edema or
Pulmonary
flooding
edema.
of your lungs. So it is reversible. Pulmonary edema, just need to give some diuretics, help them with their breathing, they get better with that. But myocardial infarction or heart attack itself is a different line of management. And the other important thing which patients present sometimes with shortness of breath is embolism or blood clot in the lung.
Blood clot in the lung.
Yes, so pulmonary embolism can also present as a failure respiratory. So as I said, the oxygen is coming to the lungs, but there's a big clot waiting in those blood vessels. It is unable to take that oxygen to the organs. So as opposed to a pneumonia, there's enough blood going around, but the oxygen is not coming to the body, which is, we call it a shunt, and the other one is called it a VQ mismatch.
VQ mismatch.
Yeah.
We talked about all these different kinds of respiratory failure and all these things, but if it happens in the public at someone's home,
Yes.
when is this bell? When do they have to suspect and it is an alarming sign?
Yes. So if it's a new thing, acute respiratory failure, shortness of breath, is the reason they should be going to the hospital. But more important, what happens in the public are the chronic respiratory failure patients. So COPD, there's a population there, fibrosis, lung fibrosis, chronic asthma or acute asthma, they have attacks. So they know their body. They know when to get help. There's a massive amount of support in the public, because the hospital, we do the acute management, but there's a COPD nurse team or community team, they can be helped. Pulmonary rehab team, which is which plays a very important part. So they visit home or they can go to the community. Physiotherapy is very important in these patients, like bronchiectatic patients. So there's a group which are in the community, which they are looked after by community, and they have, they don't need to be visiting hospital all the time.
So these are the chronic patients.
Yes.
Isn't it? But they know themselves.
Yes.
But if it happens acutely at some point in a house, I think they have to...
Shortness of breath. And your conscious level varying a bit, being a bit confused. Obviously, if you have a pulse oximeter, definitely it will be a saturation of 89, 90, which is critical. You need to go to...
Albert, what made you not to dial 999 when you had this trouble?
Because one of the worst patients will be that's in the medical profession, because we've seen the bad side of it. So you try to avoid it. I think that's plus I have a few bad instances with asthma, so I know when to get help.
Yeah.
And I know when you think that you can manage. That's why when I said that proning has helped me a lot.
Yeah.
In which, as well as I would say, taking loads of fluids, and I try to treat the symptoms as much as possible, like paracetamol for body aches and all that. But as what you said, chronic patients with me being asthmatic, I know when to get help and when it is really bad.
But did you think of a pulse oximeter at any stage when you were going through this?
I was, but at that time it is when you couldn't get anything at all.
I was trying to get for one of my friends.
Let's ask James. James, what made you that call, the 999?
Because at that time I was really sweating a lot. I think I have to change about four tops every
So-
2 hours.
So every
I was
4 hours
sitting
you
at-
change 4 tops, okay?
Yeah, I was sweating a lot. I can. Then my wife decided to call the ambulance. It was about the 13th of April, 2 o'clock in the morning. But the ambulance told us that they are very busy. The soonest is 5 o'clock, so I have to wait, coughing a lot, and my breathing is really difficult. It's like something is pressing on my chest, so I have to count and breathe properly. Then the ambulance came at 5:20, and then they brought me to the A&E.
So once you reach A&E, how long it took for them to put you in the ventilator? Did they keep you for a day or so, or did you go to the ventilator straight away?
No, I think it was 7 o'clock in the evening, because they take all my blood tests, and they came back and they decided to take me to ITU.
But that was a good call, James, isn't it? That saved your life.
That's it. But it's really difficult to leave my family, because at that time I was thinking that I will be gone forever, and that was the last time they will show me alive.
That's true.
Yeah.
Okay, thank you. Let's go back to Ramali. Let's talk a little bit about treatments and what we could do.
Yeah, so we all heard about, I think we talked a lot on COVID. So treatment is oxygen for viral pneumonia if you struggle to breathe. So you have to go to hospital. But there are other things, as Albert was saying, well hydrated, make sure your immunity is good, to take your vitamins. They have talked about vitamin C and things like that. So basically it's supporting. Whereas bacterial pneumonia, it has to be antibiotic. So the severity varies from mild. Not all the pneumonias need to come to hospital. Not all the pneumonias need to come to a ITU. So most of them could be managed in the community with oral antibiotics. If the bacterial, you give some sputum sample, they test it, and they know what bacteria it is. But most of the pneumonia in the community are viral, where you just need to keep yourself hydrated and basically, as James was telling, you keep up with your hydration.
Hydration.
Yeah, and so when it comes to bacterial
We
pneumonia,
got about 50 seconds left. So you could maybe tell them in bullet points what they could do.
yeah, so prevention is better than cure for any disease. So get your flu jabs. Winter is coming, all the viral pneumonias, and susceptible people have to be careful and basically try and live a healthy lifestyle. Stop smoking, and when you have any respiratory issues or breathing difficulties, come and get advice from your GP or hospital, and look after yourself during this winter, and don't forget the flu jab.
That's a great point, Ramali. I think you told them exactly about all program in bullet points in few words. It was a great show. Thank you very much.
Thank you very much.
Albert,
Thank
your
you.
first-hand experience and being you a medical professional as well, and you treated your COVID yourself. That's a great job.
Thank you.
And James, it was really great hearing you what you gone through and all your experience. This is really important for our viewers and what you said. And thank you very much for joining with us. And unfortunately, you could come to the studio, but we still appreciate your effort that you wanted to come in front of the television and say what happened to you. Thank you all. And thank you all for watching our program. Thank you for staying with us
Thank you
in
very
Iron's
much.
Health.
Thank you
Talk
very
with-
much.
Thank you, James.
Thank you.
Thank you.
Thank you.
For
Dr.
staying with.
Akram.
Thank you. And thank you for staying with us on Iron's Health Talk. Today we talked about respiratory failure. We had our specialist, Dr. Ramali, Albert, and James Clarin, who came via Skype. And if you have any further questions, please email us on healthtalk@irntv.co.uk or message us on Facebook or Twitter or YouTube. We will respond to you as soon as we can. So please watch us on Sky Channel 782, and we'll see you next time.